Now I'll be inviting Dr. Ashok Nataraj sir for his talk on optimizing anti-VEGF therapy in DME and nvAMD.
Thank you, Jyoti, for the opportunity. Now, after hearing this topic, then only I realized what do you mean by optimizing anti-VEGF therapy? It's a very strange term. Then only I found that, the ideal treatment for DME as well as wet AMD is give monthly injections. Keep on giving monthly injections. They all do well. Now, how do you reduce this monthly injections? You have any alternate strategies to reduce this monthly injections and make the number of injections less, but at the same time, keeping the response as good as giving monthly injections. So that is the main aim of this topic. How do you go about it? So the most important strategy to reduce the number of injections is early and prompt diagnosis. It doesn't mean that the vision is 6:6, you have wet AMD, you will wait for the vision to drop to 6:36, only then you will treat. No. Early and prompt diagnosis and early treatment. Okay, that is the most important thing. Now, the studies have shown that if you start treating after 21 weeks and if you treat at 7 weeks, there is 2.6 times of worse visual outcome in these cases. So this time is very, very important. And the treatment is in two parts. One is the early intensive phase. That is, you keep on giving monthly injections. That is something called as the loading dose. 1 injection, 2 injection, 3 injection, till the lesion becomes quiescent. So it's not that, it's 3 injections. It is number of injections. Every month you keep on injecting till the lesion is quiet. And interval between injections should be 4 weeks or less. So studies have shown that if the interval is more than 5 weeks, the patient might need twice as many injections as when it is less than 4 weeks. So that is a very important point. Now, this is one patient who has got wet AMD. We are starting the intensive phase. First injection you gave, it has become okay. You have given the second injection. Now it has become perfectly okay. The disease is quiescent. Now, one option here you have is you don't have to give the 3 injection. You start to extend the treatment at this stage only. And you can extend, instead of giving it 1 month, you can give it at 1.5 months or extend it by 4 weeks, 2 months and go ahead. So intense phase, don't keep in your mind that it is 3 injections. It is as many injections as is required to make the lesion quiescent. Now, after the intense phase, when the lesion has become quiescent, how do you go forward? Now, monthly dosing is ideal. You don't want to do that. The next best option is treat and extend. And the least preferred is PRN. But unfortunately, in our setting, you can only give PRN. PRN means the disease is quiescent. You keep on following up the patient every month. When the disease comes back, you give the injection. Again, wait. Treat and extend is like you give an injection, the disease becomes quiescent, then you extend the treatment interval by 2 weeks. You keep on injecting till 3 weeks, till the disease is perfectly okay, and then you can stop the injection. If the disease recurs, you bring back the interval between the dosing again less by 2 weeks so that more frequent injections can be given. Now, the advantage of treat and extend is all these studies, TREX, TREN, CAN-TREAT, they have said that, treat and extend is as good as monthly dosing with lesser number of injections. Now, we can even tailor the treat and extend lesion. Like, it's not that fluid should not be there to extend. Some amount of fluid can be tolerated. Like in fluid study, you can tolerate 100 micrometer of fluid. Aries trial, you can tolerate 50 microns. And keeping some fluid is actually giving some help to the RPE. And that causes foveal atrophy and that prevents foveal atrophy and long-term side effects of anti-VEGF agents. Another thing is you can extend by more than 2 weeks. In the Altair study, they have extended by 4 weeks. So up to 16 weeks you can extend and then stop the treatment. Now PRN, in the CAT trial, PRN was considered as good as fixed dosing in the CAT trial, but no other studies have proven that PRN is good. It is always supposed to be inferior to treat and extend. Now, I'll just show you a case. This is one patient who came with wet AMD. Now, you're given loading dose of Eylea. First dose, it has become less. Second dose, okay. And after that, you're going to extend. So, you gave the next dose at 1.5 months or 2 months. Patient is okay. Then you're waiting. The lesion is slowly coming back. Some amount of fluid you're seeing there. Vision is maintained. Now you can safely wait. It is kind of a modified form of treat and extend. You don't have to go and jump and inject once you have small fluid. Now again, you wait, you give an injection, the fluid is gone, patient is okay. Again, the fluid is coming back. Again, you wait, tolerate some amount of fluid. Again, tolerate some amount of fluid, but the fluid is becoming more, vision is becoming less. Again you inject, and now the lesion has become quiescent. So initially we started with Eylea, patient could not afford Eylea, now patient is on Razumab. Then again, fluid has come back. Now you go with Vabysmo, patient has got some insurance. Now after one Vabysmo, patient is okay. Then patient prefers PRN. He doesn't want to do treat and extend anymore. You follow up the patient and the patient is okay. So in real life, it is not treat and extend or PRN or fixed dosing. It's like, it depends on the mood of the patient and the mood of the doctor. Okay. So that is how optimization of anti-VEGF therapy happens in real life. Now the choice of drug, ranibizumab is there, aflibercept is there, and depending on patient economic, affordability and the kind of disease-free interval you want, you can decide on the kind of drug. Now, no activity is required, no activity is seen, futile to continue treatment, one night, all these factors, it decides whether you want to continue treatment or not. So these are the learning points: flexible dosing regime depending on the patient, modified treat and extend, improvement of regular follow-up, new molecules, and something called as observe and plan. See, observe and plan means when you have treating a patient for a long time, you know when the disease is going to recur. So if it is 3 months, it's okay. You come after 3 months, disease is recurred, give another injection. So that can also reduce the number of hospital visits. So these are the things. Now we'll come to DME. Now in DME, one thing that is different is you can tolerate some amount of fluid, edema, etc. But in AMD you cannot, because the vision really goes down fast and it is very difficult to retrieve whatever vision is lost. Now these are the DME patterns. So this is the basis. For central, we are only going to talk about central involving DME. So in central involving DME, the treatment of choice is intravitreal anti-VEGF agents. So we have the protocol I, where ranibizumab was given monthly as 3 loading doses and then as PRN. So you see the difference on treatment between AMD and DME. So DME, the established treatment is loading dose, PRN. In AMD, it is monthly fixed dosing all throughout the time. So that shows, DME tolerates some amount of fluid and, vision doesn't falls down really fast. Now, the good point about intravitreal injection is, see, as the time goes, the number of injection that is required to maintain vision becomes less and less and less. So that is one good news. And second thing is, adding laser to injection doesn't really, lessen the number of injections. You see, prompt laser, deferred laser. The number of injections become less only by 1. So that is not much of a difference. So adding laser to injection is not going to affect the outcome in that much it is not going to optimize anti-VEGF therapy. So learning point is, number of injections needed decreases with time. Combining with laser does not give much benefit. Visual gains did not differ. Visual at 5 years, proportion of patients with more than 15-letter improvement was more in deferred laser group. So adding laser is not really going to benefit in DME. So there are certain strange things that are there in DME, because DME with good vision, you can even observe. It's not like in AMD. Now, in protocol T, when patients with worse vision, aflibercept may give better visual gains at 1 year, but at 2 years, it is almost the same. So this is one patient with DME. Good sugar control, you find the DME is gone. So that doesn't happen with wet AMD. It's totally different. So optimization of anti-VEGF therapy in DME is really crazy. It doesn't follow any rules. It depends on you. And wrong diagnosis is a patient with moderate NPDR in one eye. And you can see a T-cap, telangiectatic capillary here. No anti-VEGF works, focal laser, the disease is gone. That is something that happens only in DME. And this is a cyst, it is spontaneously regressed, happens in DME, no anti-VEGF. So these are and you have this DME biomarkers which show chronicity, and that decides what anti-VEGF or steroids you have to give. So that also helps. Another thing is there is a mechanical factor called VMT. So when you have a VMT, anti-VEGF may not work and you have to think of other factors. So these are some of the points I would like to highlight. in DME, the basic difference in optimizing anti-VEGF therapy in DME and AMD. So this is one patient who had DME, 5-PED or flat irregular PED, and shows a polyp, focal laser, anti-VEGF. It's a combination of DME and wet AMD. So to conclude, like optimization in AMD, it has to be more, you have to be more careful. Intensive therapy is required, regular follow-up, loading dose, treat and extend. But in DME, loading dose, PRN is okay. And you may try alternative strategies like observation, good diabetic control. Thank you.
Thank you, sir. Thank you for that extensive talk.